Welcome once again to 10 Minutes with Harry. We recently discussed Wenckebach AV block and the footprints, how we recognise it on the ECG. Today I'd like to continue with Wenckebach AV block and discuss some of the clinical aspects, how they relate to the electrocardiograph. The electrocardiographic spectrum of Wenckebach AV block. And today I'd like to talk about the clinical aspects as it relates to the electrocardiograph. Sequence patterns of Wenckebach AV block may be 4 to 3, as shown here with the red highlight. There are 4 P waves for every 3 R waves, 4 to 3 with 1 drop beat. With 3 P waves to 2 RQRSs, it is 3 to 2, and then 1 to 1 is essentially 2 to 1 with a conducted beat and a drop beat. Wenckebach AV block can occur in younger patients, is a physiologic phenomenon and generally occurs overnight. In older patients, it can occur at any time. Here we have the ECG of a young patient during the day, and there is a normal PR interval. It's a normal ECG. At night time, however, first degree AV block occurs, and then there are Wenckebach sequences where the PR interval progressively increases, and then there is a drop beat, and the next PR interval is much shorter. This is a vagal phenomenon. Long Wenckebach AV sequences occur very commonly at night, and in this situation, there was only 1 drop beat in a full 24 hours, and this is not unusual. The older patient, however, has Wenckebach at any time of the day or night, and generally always have first degree AV block as well. Here is a symptomatic Wenckebach AV sequence. The patient has a rate of 40 beats per minute on a routine 12-lead ECG, and then there is a Wenckebach sequence resulting in a 2.4 second pause. On rare occasions, these pauses can be symptomatic, and the patient even may require a pacemaker, although this was a very unusual situation. The electrophysiology of Wenckebach second degree AV block is that it may occur with a narrow QRS. It is AV nodal. It's 4 to 6% of Holter monitors, rarely symptomatic, as I stated, reversed with exercise or atropine, but occasionally it may be intrahiscine, where it is worse with atropine, and in that situation, in fact, may result in syncope and the requirements of a pacemaker. The wide QRS scenario of Wenckebach is still 75% in the AV node. It just happens that Wenckebach occurs in the node, AV node, which is common, and a bundle branch block occurs as well, which is also common. However, 25% are intrahiscine or have a bundle branch block and therefore may be symptomatic, and pacing is required. Here is such a situation of a Wenckebach AV block sequence with a bundle branch block. It's 3 o'clock in the morning. Once again, you see the typical Wenckebach sequence, 220, 300, and 360 milliseconds. There is then a drop beat and then a short PR interval of 280 milliseconds. This again may not be distal, but rather it is 2 separate conditions. Most are still AV nodal. Wenckebach AV block is physiologic at high atrial rates. We're all fully aware of this. For instance, here is an atrial flutter with a 1-to-1 ventricular response. This is an unusual situation because atrial flutter with a rate of 300 usually has a 2-to-1 at least block, and so the rate is 150 beats per minute. The AV node is a blocker. It sits there and acts as a gatekeeper to prevent impulses coming through too quickly. Here is the normal scenario of atrial flutter with 2-to-1 block. So rates of 180 to say 220 can still have a block occurring. But shorter than that, faster than that, it's always going to be a block. Here is an exercise tachycardia, 120 beats per minute, with a bundle branch block. And you can see here that during the exercise, there is a prolonged PR interval and a drop beat, so that this is a typical Wenckebach sequence, but it occurs at a very low rate during exercise. And in this scenario, one always thinks of a distal cause, and this may be of concern, particularly if a patient is symptomatic. Pacing may well be required. Thank you.